As much as I defend the NHS, its funding of optometry reflects a bygone era and has never been updated. Mr. Aaron in 1949 would be totally familiar with the current system. An NHS sight test is extremely rudimentary. Its sole point remains simply to prescribe optical correction. Anything else should be referred to secondary care, who then charge your GP surgery for the service. So the common practice in community optometry of pushing through rapid, underfunded sight tests to ensure more high-value spectacle sales clearly reflects this funding. There is no time allocated for complexities. I decided last century I did not agree with this model, which in my opinion drives poor clinical practice. So despite funding issues, we at Aarons took the time-consuming, expensive and risky path toward medical optometry. We now manage many conditions as independent primary care clinicians, not screeners, but these advanced services remain unfunded. And as the sole medical optometrist in the region, the clinical workload continues to increase, which is great. It is what we've been trained to do. But the value no longer lies with the spectacle outcome, but with the clinical service. So since the NHS does not fund community-level medical investigations, should we simply follow the high street model and not offer them? Well, actually, in my opinion, we have no right to dictate what a patient may or may not value. Our professional role is to make sure people have choice. Especially as we age, the clinical value should take precedence. But we also understand, especially young, healthy individuals may not benefit from all our additional skills. Hence the two-tiered system. So what should patients value? Well, first and foremost, time to investigate and time to communicate. Just measuring things and punching info into a computer might be quick, but does not reassure a worried patient. I find a significant role is advising patients what they have not been told. Time to answer their many concerns involving general and ocular health, confusion over drug lists, as well as explaining what consultant letters actually mean, and advising on risks and benefits of procedures. This all takes time. Does it allow us to sell more glasses? Well, of course not, but it is an extremely valuable service for the patient. My vision of optometry cannot be achieved without advanced qualifications. Debbie, Andrew and I have been amassing additional qualifications since 2001. The new guard, Sam, Sarah and Amy, are rapidly catching us and will probably surpass us. This is as it should be. In a modern clinical environment, not striding forward is going backwards. Between the six of us, we have every subspecialty covered. Importantly, if during a medical ocular exam, another subspecialist's opinion is appropriate, this is automatically part of the enhanced service. This represents a huge investment in time and money for Ashington and our patients. Supplying the service we do demands continuity of care. You don't want to have to start from scratch with a new optometrist every time you turn up. All our optometrists are permanent. Debbie, Andrew and I have upwards of 90 years continuous clinical coverage at Aarons, almost unheard of these days. And I'm extremely proud to officially introduce Sam, Sarah and Amy, three highly motivated young optometrists totally committed to the Aarons ethos. These people will ensure continuity of care for the next 30 years. Constantly investing in advanced technologies, including AI, is actually given. However, anyone can buy a fancy kit. It is the interpretive skill of the clinicians which is critical. Accruing clinical data, yep, important. Communicating outcomes to a patient, vital. So, full ocular exam versus quick sight test. Put simply, if your only reason for requesting a sight test is to obtain a prescription for glasses, then a non-medical check is acceptable. We still allocate 30 minutes for this. There are no 20-minute tests here. However, if it transpires other things are implicated, involving cataracts for instance, an upgrade, as we've always done, would be recommended. If you do not value our skills for this, then referral to secondary care can be arranged. A medical ocular check is critical when your primary reason for presenting is not simple optical correction. We deal with a huge array of ocular problems and GPs refer to us for many health-related issues. In these situations, 45 to 60 minutes is mandatory. And actually, many people simply value extra time to fully understand their visual frustrations and unique lifestyle needs. None of us are generic robots. We will not take the easy high street option of speeding up test rates to sell more spectacles. It would not improve your care. We would be abdicating responsibility.